My name is Megan Scott Hansen, and I would like to present to you a brief overview of the U.S. healthcare system. But to fully appreciate the strides we have made over the years, I need to start in the 1600s, back when the colonies were first established. So in the beginning, many of the so-called doctors in colonial America had no formal medical training and practiced medicine based on medieval concepts of the human body. Aggressive treatments such as bleeding, purging, and blistering patients occupied a central place in therapeutics. People also used leeches to suck the diseases out of their bodies. Thankfully, the movement toward health professionalism took a dramatic leap after the founding of Pennsylvania Hospital in the early 1750s, the first mental hospital for assisting the insane, and the charter of their first medical school in Philadelphia in 1765. By the time of the American Revolution, the country had up to 4,000 physicians. In 1789, President John Adams signed the Marine Hospital Fund into law, and Marine Hospital became the first publicly funded, prepaid health insurance programs in U.S. history. Not only did it provide care for ill and disabled seamen, it also helped guard against port entry of diseases. So now that there were medical staff and facilities, America needed to improve their standards and help citizens access care. Therefore, the American Medical Association was founded in 1847. Then, the Department of Public Health was established in 1879. And that was a direct outgrowth of the Marine Hospital Service's original charge of controlling major epidemic diseases. In 1929, a group of teachers in Dallas contracted with Baylor University Hospital to provide a set number of hospitalization days in exchange for a fixed payment. And this was an early form of health insurance. By 1920, more people were living in cities than on farms, mostly for employment reasons. And with the migration to the cities, the concept of taking care of extended family members too old or infirm to work disappeared. In addition, Americans were living longer, thanks to better health care, sanitation, and public health programs. The Great Depression prompted the federal government to address the growing problem of economic security for the elderly. The result was the Social Security Act of 1935. In 1965, President Lyndon B. Johnson announced his program to create Medicare and to launch his war on poverty with Medicaid. These new programs aimed to improve health care for the poor and aged, who at this point had limited access to quality medical care. Significant changes were underway in the structure of healthcare by the 1980s, a time often referred to as the age of privatization. The government redirected its policies toward privatizing publicly funded institutions, and hospital systems were integrated into larger healthcare networks. Marketing practices, including direct-to-consumer advertising for pharmaceuticals and medical devices, increased significantly. In addition, contracting work to third parties and government deregulation were becoming standard practices. As such, patient privacy became a significant issue in healthcare, and in 1996, the federal government responded with the passage of the Health Insurance Portability and Accountability Act, also known as HIPAA. The primary goal of HIPAA is to make it easier for people to keep health insurance, protect the confidentiality and security of healthcare information, and help the healthcare industry control administrative costs. On March 23, 2010, President Obama signed the Patient Protection and Affordable Care Act, also known as the Affordable Care Act, into law. It is the most significant government expansion and regulatory overhaul of healthcare since the 1965 passage of Medicaid and Medicare. It is hoped that the law will increase health insurance coverage, reduce costs, streamline delivery, and improve outcomes for all Americans. So who are the stakeholders in this? Well, everyone in America is a stakeholder in regards to healthcare. The four major groups of stakeholders are healthcare professionals such as yourselves, patients, political figures, and schools. Healthcare professionals provide healthcare services, follow regulations, and protect patient rights. Patients choose their insurance, how they will respond to medical advice, and if or when they will receive care. Political figures use their power to alter the healthcare system, to gain the vote of their constituents, to protect patient citizens, and to change the economy. Schools teach children about the history and nature of the U.S. healthcare system, educate the healthcare professionals, and conduct many research programs regarding medical care and interventions. So now that we understand where we started and got to this point, how are providers reimbursed for this medical care? Let's look at our current system for costs. There's 4 systems for reimbursement. There is fee-for-service, which is the oldest form of medical reimbursement. In this system, healthcare professionals are paid for every service and test they provide. In contrast is capitation. A healthcare provider receives a fixed, pre-arranged monthly payment per patient. And this monthly payment is calculated 1 year in advance and is fixed for that year, regardless of how often the patient needs services. Next, we have pay for performance. And this payment arrangement provides financial incentives to healthcare providers to carry out particular improvements and achieve optimal outcomes for patients. And finally, the value-based model of reimbursement, which aims to improve quality and reduce costs by creating incentives for providers to deliver high quality rather than volume-driven care. Providers receive this reimbursement mainly through private and public insurance. So let's first look at private insurance. So in private, you have managed care organizations that enter into contracts with hospitals and healthcare providers to provide healthcare to their beneficiaries in exchange for a negotiated rate per patient. So first you have HMOs, which epitomize the managed care model by offering a hybrid health plan that combines healthcare insurance and health services. The primary strategy of HMOs to reduce their costs is the practice of gatekeeping, which keeps patients from accessing specialized health care without first visiting their primary care physician for a referral. So the first type of HMO established was the staff model. And this model employs its own group of physicians to provide most of the healthcare needs of its subscribers, and it then contracts with medical specialists. The second type, which is the most common type of HMO, is the Independent Practice Association, which consists of community-based independent physicians who form a for-profit HMO. Next, you have the Preferred Provider Organization. It is similar to HMOs in which you enter a contractual agreement with a healthcare provider to put together a provider network. However, PPO primary care physicians do not function as gatekeepers, and instead, the patient may go directly to a specialist for care, as long as that specialist is within their network. The third type of managed care organization is the point of service plan, which offers the consumer both an HMO and PPO plan in one product. So patients can choose which plan depending on the provider they see. They can benefit from the financial savings of a more traditional HMO at certain times, but they still have the flexibility of choosing a physician with the PPO. Next, let's look at public insurance. So first we have Medicare, which is a purely federal program. Therefore, the federal government establishes the rules for eligibility, the benefits that are covered, and how healthcare providers are reimbursed. It is financed by a combination of payroll taxes, government revenues, and premiums paid by the beneficiaries. Next is Medicaid. It's a government health program for the poor and medically needy. Individuals must meet certain minimum requirements to be eligible for this program. And although it's funded through federal and state taxes, it is administered by the individual state. Children's Health Insurance Program provides health coverage to children who are not eligible for Medicaid, but are unable to afford private insurance. Although the federal government regulates it, CHIP is designed and implemented by the individual state. And similar to Medicaid, funding comes from a combination of state and federal taxes. The Federal Employees Health Benefits Program is one of the largest employer-based health insurance programs in the country. It is more similar to managed care programs than to Medicare or Medicaid, and as such, federal employees can select from a variety of plans. Similarly, TRICARE, which is the Department of Defense's health insurance program, offers a variety of managed care options for beneficiaries in the uniformed services. So, what is technology's influence on cost and quality? Well, in terms of patient care, technology has undoubtedly been a significant driver of change. It has also been credited as one of the primary causes of the high costs of healthcare. Electronic health records can improve the quality of healthcare by helping doctors and facilities share patient information, but it is a costly technological investment, as is medical research and personalized medication, which is expected to increase survival rates, improve quality of life. However, the long-term outcomes, although they are cost-effective, initially the cost of the new diagnostic tests and individualized drugs can be more expensive. So let's compare our system to Sweden's, just to get an international perspective. So in Sweden, affordable healthcare is available to all residents through an extensive tax-subsidized system. In Sweden, patients choose their own PCP, and if they need referrals for a specialist, the PCP provides those referrals. Dental services are free for Swedish citizens until the age of 20. It is up to the counties and municipalities to set the fees that patients are responsible for. However, there are out-of-pocket maximums for citizens within a 12-month period, which for medical care is roughly $135, and for prescriptions is about $296. Sweden also offers a wide range of unique services. They are known for their focus on trained professional midwives, and research shows that this has resulted in a sharp reduction in mortality among women in childbirth. Most counties do not charge children and adolescents below the age of 20 for appointments at health centers, youth clinics, or other outpatient facilities. Unlike the US, where we are working towards a universal EHR system, Sweden already has a national electronic health system that includes electronic patient records, e-prescriptions, and web portals providing healthcare information. Also, if a patient is diagnosed with a disease that is a public health danger under the Communicable Diseases Act, their care and medication are free of charge. There are many great aspects to Sweden's healthcare system. In addition to the aforementioned facts, Sweden gives healthcare access to all citizens. The fees associated with those services are low, and the elderly in Sweden have the right to receive care in their own homes. However, the system is not perfect. In addition to all the great benefits of their healthcare system, there are some downfalls. The citizens are taxed heavily. The wait times to see a doctor can be up to 7 days, and the system is not patient-centric. So, although they may be more advanced in some areas, how do we compare? Well, we both offer emergency services to our citizens, and we focus on patient safety incentives. But Sweden is more advanced when it comes to a national health record system, and we differ vary on Planned Parenthood methods and access. But what does our future hold here in America with reforms and improvements? Well, the Telehealth Enhancement Act of 2015 will promote and expand the application of telehealth. And by current estimates, nearly 2 in 3 uninsured low-income individuals who would qualify for subsidized affordable care coverage may not receive it if their states do not accept the expanded Medicaid program. But there's still time for states to adopt the expansion, which hopefully will happen and, help a lot of Americans. There's also the Patient Freedom Act, which will reform the provision of health insurance coverage by promoting health savings accounts, state-based alternatives to coverage under the Affordable Care Act, and price transparency. And then we have technological improvements, which will standardize care and could save up to $2,500 per member per year for insurers. In addition, automatic and online scheduling, kiosk, check-in, e-billing, and online test viewing can reduce administrative costs. In the next 10 years, we are going to see a dramatic leap in technological advances. We already have medical apps on phones, telemedicine, robotic surgeries, genetic testing. We can only continue to advance these current technologies and future technologies that we haven't even thought of yet. The future of healthcare is a digital world. However, we must be careful that we use such innovations within the ethical boundaries required of the awesome responsibility of saving and improving the lives of our fellow man. I also believe that with the passage of time, we will see the U.S. offer universal healthcare to all citizens, as we hold these truths to be self-evident, that all men are created equal, that they are endowed by their Creator with certain unalienable rights, that among these is life, and may it be a healthy one. I wish you all the best of luck. Thank you.